actually one of those. Sickle cell is actually one of those diseases that brings together both pathology, it brings together natural science, it brings together genetics, and it also brings together genomics. And back in, once you look at diseases like sickle cell, you get to realize that it has been in Africa for quite a while, for many centuries. But it's amazing that the world did not know about sickle cell for over almost hundreds of thousands of years since man's existence. In Nigeria and in some part of Cameroon and in all African cultures, in Nigeria in particular, the word obanje used to mean a child who comes and goes, meaning that they used to think that these children were cursed. A child that comes and goes, meaning the child is going to be born, then the child is going to die and the child keeps coming back and you need to break the cycle. So you have to go leave the child in the water and abandon the child. All of this was sickle cell, and every culture had a name of calling these children. These children were so sick and complicated that the word obanje has stayed. And that is actually, a lot of people have heard that word obanje, but they don't know exactly where it comes from. You do have it, we had to take almost, sickle cell was first really described 100 years ago, meaning that there was a student who came from Grenada to Chicago and got sick. He was a dental student, he got sick. And one of the interns, meaning a doctor who was specializing, got interested in this child, in this guy, and decided to do a blood smear and look at the blood work and saw that the cells were sickled. Then he described it as sickle cell. You can only imagine that Africans left Africa and moved to the United States and stayed here for 400 years and no one ever diagnosed them with sickle cell. It shows you how health issues are actually a political issue. They can actually be health discrepancies and something that you do have up to today. So going into just looking at sickle cell, not all sickle cell patients are the same. And this actually has led to a lot of other developments. And back, Allison is the guy who described the links between sickle cell and malaria. He observed that in Kenya, when you look at sickle cell, there were more people who had the prevalence of sickle cell gene in them, those who are carriers, but there were no sickle cell patients who were sick. He wanted to find out, why are there so many people carrying this gene, but there are not many people sick? That was an easy explanation. Most of the children died when they were young. The second explanation is sickle cell prevalence was greater than that which is predicted by all medical knowledge you can think about for a genetical disease which is not a dominant disease. So there must be a factor that is pulling the sickle cell to stay in our environment. And he realized that areas with high level of malaria actually had more people who actually were carriers of sickle cell. And that you can also see in Cameroon. If you're looking at the prevalence of malaria and comparing it with the prevalence of sickle cell, it correlates. So sickle cell disease is a disease that is found on something called our chromosomes. To those who are not in the medical field, there is a mutation that occurs on chromosome 11, which carries a beta gene, which is part of what makes red blood cells. There is mutation in just one amino acid and causes this amino acid, which makes glutamic acid is replaced by valine and leads to all of these problems that we're going to talk about today. This is what you call a sickle. A sickle is this instrument here that is used to cut grass. And once this mutation occurs, the cells look like this. That is why they described it as sickle cell, just because of this thing called a sickle. So you have red blood cells that look sickle, patients become anemic, patients develop vaso-occlusive crisis. We'll talk about some of them. These are just pictures of different microscopes showing you what a sickle is. Here, it tells you exactly how this disease is transmitted. I put an equation here. This shows you it's kind of detailed genetic, but there is nothing there. All we need to know is that know exactly, test children, test parents. We should have informed consent when we're getting married and know exactly what is good and how to do about this. It doesn't mean sickle cell patients cannot get married. A sickle cell patient with SS getting married to someone who is AA, they will have no child who is actually going to be sickle. And so If someone who is SS gets married to someone who is SS, all their children will be SS. Someone who is a carrier gets married to another carrier, they will have a 25% chance of giving birth to a child who is actually a sickle cell child. And if a sickle cell patient gets married to someone who is a carrier, they will have a 50% chance of giving birth to someone who has sickle cell. So the burden of the disease is in Africa, really. Once you look at it, you realize that the burden of the disease is really in Africa. And you would also get to realize that just by looking at this, Nigeria alone has the highest number of sickle cell patients in the world, by far. Cameroon has a burden. The Democratic Republic of Congo also has a high burden. These are the areas where sickle cell exists. Africa carries about 80 to 90% of all sickle cell patients. Cameroon, the prevalence of sickle cell varies from 8% in some regions to about 34% in other regions, as I told you, depending on the prevalence of malaria. And the prevalence of sickle cell trait in Cameroon is about 18.2%. That's the trait, those who are carrying the disease. It's what we are expecting. In Africa, the reasons why we have this high prevalence is because of malaria, as I explained before. Proving that this is true, all the Africans who moved out of Africa through slave trade and went to the rest of the world, the prevalence has dropped. Gone back to the Heidi Weidelberg prediction that a recessive disease actually has to turn to disappear unless there is a genetic factor which is pulling it and keeping it to stay. Those who are AS have an advantage. A genetic advantage is that they get less severe malaria. So those who are AA die from malaria. Those who are in the past, when there was no treatment for malaria, those who are SS die from sickle cell, and those who were AS stayed. So this was a genetic pooling. This is the amazing story of sickle cell and hemoglobinopathies that we study in hematology. Amazing to see all of this, that you have an explanation. So WHO actually reports that you have about 300,000 children who are born of sickle cell every year. 25% to almost 80% of them live in sub-Saharan Africa, including our country, Cameroon. Not all sickle cells are the same. I know I've heard, I'm a sickler, I'm never sick. Others will say, oh, I am a sickler and I'm always sick. I'm going to explain to you. Sickle cell has phenotypes. They are not tested in all countries the same. So you could have hemoglobin SS. There are those who have SC disease, especially in West Africa. There are those who have sickle thalassemia, both thalassemia minor and thalassemia major. The sickest form of sickle cells are the SS disease and the S thalassemia minor. Even when we talk about sickle cell SS, this is a bit some real detailed genetics I will tell you guys today. Not all sickle cell SS patients are the same. If you do what you call a phenotyping in these genes, you realize that this mutation had occurred many times in human evolution. So the haplotypes of sickle cell are different, meaning that the amount of hemoglobin F, which protects people, that people produce, are different. So you do have what you call a subtype called the Benin type, the Bantu type, the Senegalese type, the Cameroonian type, and the Asian type. The sickest sickle cell patients are those who inherited the Bantu because they produce the least amount of hemoglobin F. We don't test this regularly, but this is something you just need to know for your knowledge. If someone asks you later on, these are the distribution. We are fortunate to have a Cameroonian type too. As I said, the Central African type or the Bantu type actually has the lowest prevalence of hemoglobin F. This is the culprit behind sickle cell. Each time someone tells you sickle cell, this is what really led to us having so much number of people having sickle cell in Africa. If you look at the correlation between sickle cell and malaria, you realize that everywhere you had malaria historically, you do have sickle cell. In areas where there was no malaria, there's no sickle cell. It does not mean that this mutation did not occur, but the mutation could not last. It lasted in Africa because there was a genetic pooling. Those who were AS were actually being protected. Same thing with all hemoglobinopathies, which I'm not going to talk about today. Thalassemias, you have hemoglobin C disease, E disease, D disease. They are all related to where malaria was prominent. So malaria has been a pulling force. What is the natural cause of sickle cell patients? If we do nothing to sickle cell patients, what happens? Most sickle cell patients in Africa actually follow the natural cause. We've not been doing much. Some of them are going to stay, but 90% of them are going to die before their 5th birthday. That occurs in Cameroon. 80% of our patients die before their 5th birthday. We have studies which were done in Jamaica, and some of them were done in the United States. Since we started taking care of sickle cell patients, survival has drastically improved over time. And Africa is still being left behind, especially our country, Cameroon. And that is why we're talking about this. We have very limited access to treatment. So although sickle cell life expectancy is influenced by genotyping, as I told you guys, the severity of the disease is also influenced by gene modification, by the amount of hemoglobin F, coexistence with thalassemia. There are other things: geopolitical environment, availability to hospitals, training of physicians, socioeconomic factors, nutrition. I think Echi talks about nutrition all the time. Access to care. It's a big problem. Here is a complex diagram. I'm not going to waste time on this, but it's just to show you the kind of hemoglobins we produce. This is very important. Most of the time, like my grandmother never knew, my great-grandmother never knew that her children were fine till they were 6 months old, meaning that when humans are born, we do produce fetal hemoglobin that protects us up to about 3 months is maximum. It starts going down. 6 months is almost zero. At that time, these children start producing a hemoglobin, which is hemoglobin A1. And at this time, that hemoglobin has the chance of being sickled. So these children tend to start being sick from 6 months going ahead. And that is why these children start having crises. And everyone attributes it to this child who is an Obanje, who is cursed, who is cursing the family. And this is really what has happened and has led to us not tackling the disease. So recently, there have also been a lot of discoveries in sickle cell. There is gene editing where we are able to edit genes and be able to cause this switching off of hemoglobin F to not happen. This is actually where the disease is going to, where we can give therapy to people who are already adults and make them to be able to produce hemoglobin F and be able to stop the progression of this disease. So this has been done before, and there is a lot of data in this. This is just one of the studies. I'm going to talk about it. Now, why do people actually with sickle cell fall sick? They do fall sick because of this mutation I told you occurs at position 6 of chromosome 11. And what really happens is that the cells become very stiff and they are unable to circulate in your bloodstreams. So they get tight in what you call the capillaries. They block them. And what happens? All organs need blood. Once you're unable to get blood, what happens? You die. The organ is going to die. Those organs die slowly. So there is what we call polymerization. These are the different things that occur microscopically, which inflammation occurs in our vessels. We also have adhesions and many other things. So here are the different markers we are trying to target in order for us to be able to treat these sickle cell patients. And we have been really trying to do a great job. The past 4 years have been the best years for sickle cell patients. And what are the different types of patients that you would see in your clinic if you're able to see sickle cell patients? In Cameroon, most of the time, the diagnostic method we are unable to identify the difference between sickle cell thalassemia, sickle cell C disease, and sickle cell SS disease. But these patients actually manifest sickle cell with different levels of severity. The SS is usually the most severe. The S thalassemia minor is also one of the most severe cases, while the others are actually not as severe. So sickle cell patients can have multiple complications. It's a summary of all of internal medicine that you want to look at. If you're looking at a sickle cell patient, they actually do have a summary of all of internal medicine. And it's really amazing to see that these patients we have actually gotten to a point where we can actually help them. So these patients have problems with meningitis, they develop strokes, they develop sickle problems with their livers. They have problems with their gallbladder. They do have problems with the bones. There is infections. They have problems at the level of their eyes. They will need eye checks. They have problems with hypertension. They have problems with at the level of the chest. They have acute chest syndromes. They have sepsis. They have all these complications, which we're going to discuss, not in detail, but just talk about them. What is the mortality of sickle cell? So how does Cameroon compare with the rest of the world? How, if you're born a sickler, what's the chances that you're going to live? So the median age which sickle cell patients die in Cameroon is about 18 years. So you see that our warriors are really doing some good things. Nigeria is 21 years. In the US where I am, it's about 48 years. I have patients in my clinic who are 75 years old. What kills sickle cell patients the most is acute chest syndrome. There's also infection, which is a cause of death. How do we diagnose sickle cell patients? We do something called electrophoresis, meaning that we take their blood. That's the easiest way, but there are other ways, even genetic ways of diagnosing them. And we need to be able to take care of these patients as life goes on and be able to treat them. So we have diagnostic issues. There is no screening of sickle cell of patients who are pregnant in Cameroon in order for us to be able to actually screen these children. It's not a universal policy to screen all pregnant women and be able to identify those who are sicklers. That is something that the government can work on. So each time you have a sickle cell patient, you have to be able to do some basic lab work to understand how they look and be able to treat them, and then be able to understand how you're going to manage them. How do these patients present in our hospitals? Most of them are anemic. In Cameroon, we have access to blood is a big issue. Access to lab tests is a big issue. If you're living in one of the big cities, you have to bring a friend or a family member who will come and donate blood, pay 5,000 before you get the blood. At times, all of this leads to us really having people dying because they are unable to access health. Most of them, 12% of sickle cell patients will develop a clot in their lungs, in their legs, and will need to be able to manage them. But the most common thing that brings sickle cell patients to the hospital is vaso-occlusive crisis or pain crisis, meaning that a lot of them come in when they are sick and they are having pains, which is one of those things we should know about. Why do they have pain in the first place? They are dehydrated. They have temperature changes. They become emotional or physically stressed. They get infections. A lot of them develop asthma. Some of them just have sleep apnea. Some of them get pregnant. All these stressors actually lead to them developing what you call acute vaso-occlusive crisis, meaning pain, dactylitis. They are actually feeling pain all over the body. There is a whole part. I put in a lot in this slide so that those who are interested, I can share it with you guys later, but I'm not going to go into all the medical issues. They have hand and foot syndrome when they are young. As I put it there, they have pain. They tell you they're feeling so much pain in their hands. These children, you need to examine them well as physicians, and those who are physicians here. Those who are in the lab, we need to do the proper lab test. You need to be able to treat them. I know we give them a lot of fluids, which we have to be able to give them, but we should be careful. The kind of fluids that you give them is important. This is just to help those who are doctors here. Use half normal saline. Why? Because normal saline causes crystallization and makes the cells sickle more. There are other techniques like relaxation, warm, using oral and hydration, and also using pain medications, which is very important. We have little access to opioids back home in Cameroon to actually help some of these patients when they are unable to control their pains with anti-inflammatory. So there is a multifaceted problem to even help these patients. There is lack of access. Few doctors are trained to take care of sickle cell patients. No adult hematologists actually exist in most hospitals. And these patients, even when they get to adulthood, the access to treatment is very difficult for them. Pain management is very important, and the techniques of doing pain management. Hydroxyurea is something we use and we talk about all the time, but the access in Cameroon and in Africa is really non-existent. I know there are a lot of people who are sickle cell patients who are taking hydroxyurea, but most people do not even have it. These are some new medications that just came up: L-glutamine, crizanlizumab, and vosalotol. And I think most of them are not available in Cameroon. So hydroxyurea has existed for more than 30 years. but its access in Africa has been very, very minimal, and it's life-changing. It reduces the crisis by 50%. L-glutamine was just recently FDA approved about 3 years ago. It's one of the new child in the block. You do have crizanlizumab. It's a once monthly infusion that is given to these patients. And it also reduces crisis by almost 50%. And Vosalotol is another medication that has been approved. So the HASH, which is the American Association of Hematologists, took sickle cell seriously about 3 years ago, and they have led to a lot of research and new medications have been developed. Your goal with these patients is to actually prevent or to silence complications. You don't want them to get any complications. And you don't want them to get both acute pain crisis, chest syndromes, and all of those things. And to monitor them and train physicians and train them to be able to identify their symptoms early. At the level when the child is still young, you want to screen them, identify them, prevent them from having strokes, which is going to lead to a lifetime debilitation. Also, you want them to check their eyes. You have to educate the patients, provide antibiotic prophylaxis, vaccinate these patients well. We also have to be able to measure their growth, make sure they grow well. Also, neurocognitive assessment, dental hygiene, immunization, wellness of wellness in a child needs to be emphasized when they are young. So if you don't take care of these children when they are young, identify them, which we don't screen our children for sickle cell. Those who are wealthy do it, those who are not, do not. Sickle cell affects all organs in the body. Name an organ, it affects it because blood goes to all organs in the body. So pain is one of those things a sickle cell patient. I used to have a sickle cell patient in my hospital. They are playing on their phone and other doctors feel they are pretending. They are just using a strategy in order for them to forget about the pain. So they are using coping mechanisms. So in order to take care of pain is not only medication. There is social and cultural perception of pain. There is emotional and motivational factors that people use. There is cognitive and perceptual thinking, the way they do support themselves. Sickle cell pain crisis in itself reduces quality of life. People don't go to school. I know children who have missed school. I know difficulties that it has caused in families, mothers unable to do any activity because they have to take care of their child who has had a stroke. Patients having pain crisis all the time, failure to strive, failure to grow, transitioning to adulthood and not being able to have an adult doctor who even understands your disease very well. It's really one of those things, being hospitalized all the time and not being able to even have a life. So multidisciplinary teams need to be educated in Cameroon. The next thing I will just lay an emphasis on is acute chest syndrome. This is one of the biggest reasons why sickle cell patients die. They come into the hospital, we think it's just a regular sickle cell crisis, they're having an acute chest syndrome. The good thing with COVID is that it has enabled most people to have a pulse oximeter so they are able to measure the oxygen of patients. So measure the oxygen of your sickle cell patients who come in with crisis and fever, and be able to identify that they're having an acute chest syndrome and treat them. So what are the causes of this? All infections and several things can lead them to have acute chest syndrome. Most of our hospitals do not even have an X-ray machine, so we're unable to even know if they have acute chest syndrome, if they even have new infiltrations in their lungs. So we see that we are backward. So much has to be done. Even once you identify them, how do you treat them? In severe cases of acute chest syndrome, you're supposed to do an exchange transfusion. We do not have exchange transfusion back home in Cameroon. And you can do a simple transfusion, it may help, but you have to always start them on empirical antibiotics. These are the modalities of treating patients actually with acute chest syndrome, and we see it's a big problem, it's the #1 killer. Our approach to it is totally still lacking. Patients may have an aplastic crisis, meaning that their bone marrow stopped producing because they are infected with parvovirus B19. In this case, you need to do supportive care and transfuse these patients to stay alive. We have problems with transfusions, as I said earlier. It's still a big problem. The next thing you could have, patients could have what they call hyperhemolytic crisis, meaning that these patients actually are having destruction of their blood everywhere. You have to be able to not transfuse them. Here, most of the patients are being transfused because we are unable to determine the difference between these crises. Patients who are young, also their spleen, the splenic sequestration, this is actually a very big crisis in children and leads to the mortality of most children. They become hypotensive, they get into shock, and they die because no one identifies it. So you see a child here who just had a splenic crisis. You need to actually hypertransfuse them and provide them with supportive care. So sickle cell affects all organs in the body, as I said before. I'm just going to show you a picture with every organ and showing you that it affects every single organ. Some people may just present with multi-organ failure, which here you need to do an exchange transfusion, which is not available back home. It is sad, but that is the truth about it. So the next thing is infection. Sickle cell patients are prone to getting infections, and they get infected with encapsulated bacteria because their spleen, which is an organ that helps you to kill infections, is no longer functional. That is why they need to be vaccinated against all of this. In infections, you need to treat the different infections they get, but you need to provide them with essential vaccination, which is very vital. With COVID coming up, we're talking about vaccines, but you need to also treat them with fourth generation and third generation cephalosporins. That will be a discussion another day. Strokes. These children, before the age of 5, they usually get a stroke. Some of them, if they are not well taken care of. And how do you prevent strokes? Is you have to keep transfusing these children, especially those who have had a stroke before. So, and if a child has a stroke, you have to do an exchange transfusion and provide them with aspirin. We do not have exchange transfusion. I'm just insisting on this, showing you how taking care of these children can be very difficult in this case. This is something called Moyamoya disease. If you do an ultrasound in the child's head, you would see that a lot of their vessels are this way. It's actually a translation from a Japanese language that means a puff of smoke. So these children have these abnormalities and they are prone to getting strokes, multiple strokes. They could also have a hepatic crisis. They could also develop chololithiasis because there's red blood cells. The life expectancy of our red blood cells is about 90 days. Theirs is less than 90 days. So the cells die more. And because the cells die more, the components of the cells that are eliminated stay in the gallbladder and they can cause chololithiasis or something called stones. So these patients can also have kidney failure. So most of them, before the age of 30, they develop, their kidneys fail. That's why a lot of patients, even back in Cameroon, who are getting hemodialysis are also sickle cell patients. So you get to see that in males, they can have priapism, meaning they have an erection that does not go away, and it becomes and actually can render them impotent. You need to do exchange transfusion in order to help these patients at times, and you need a good urologist, and we lack all of this back home. Some of them may develop pulmonary hypertension. Taking care of this disease is very difficult. Eye problems, as I said, you could also have problems with the bone, osteoporosis, osteopenia. They develop ulcers. Some of it could be complications from the treatment, but most of it is complication from sickle cell itself. And in order to manage these patients and long-term, we need to prevent infections, complications, and be able to see that these complications do occur in sickle cell patients and understand the disease itself. Provide essential vaccination, which is not provided by our PEV or the essential vaccination in Cameroon. So sickle cell in itself, if you don't understand it, you will not be able to take care of these patients. Now, what are the different modalities of treatment? As I said before, there's hydroxyurea. Accessibility in Cameroon is very low. Education about it is very low. It's a drug we use for cancers, but we can give it to sickle cell patients. All sickle cell patients who have more than 3 crises a year are supposed to be on it. It reduces the number of crises by 50%. We also have to be able to have a good blood bank system. In Cameroon, our blood bank system is failing us, and this is failing sickle cell patients and failing others. We do not even do hematopoietic transplantation, which can be a cure in young patients, especially those who are less than 5 years old. You can actually cure them by transplanting these patients with a bone marrow from a sibling who does not have sickle cell. So you see that there are several approaches to sickle cell, curing sickle cell itself, using genetic therapy, using transplantation, disease-modifying agents, which I've spoken about some of them, and then the palliative care which we provide to these patients. Over the years and recently, there has been a new interest in sickle cell in the United States. I live in New York. We have the highest number of sickle cell patients in the United States. The Bronx in New York City has the highest number of concentration of sickle cell patients in the world. Meaning, if you go into the Bronx, the highest number of concentration of sickle cell patients in the world live there. Nigeria has the highest number of sickle cell patients in the world. Looking at how diseases that affect Black people really have little research. HIV just occurred 40 years ago. We have 22 medications for HIV and counting. I think the number has actually increased to about 28 now. Sickle cell, since its existence, and since it was discovered more than 120 years ago, we have just 4 medications for sickle cell. Cystic fibrosis that affects less than 0.001% of people, but it affects Caucasian more, has 9 medications. You can imagine the negligence in the scientific world. For those who are interested in knowing the medications and how they work, you can look at this in my slides. And just important to know, you can give hydroxyurea in anyone who is above 2 years. And this was the journal that presented hydroxyurea. You can see it was discovered in 1995, but up to today, the access in Africa is very poor. It actually increases the amount of fetal hemoglobin, which I spoke about, and reduces the crisis. The only big study that was done on hydroxyurea was sponsored by Novartis back in 2019 to show that hydroxyurea works in Africans. Can you imagine that? It took us another 30 years to do a study among Africans. So this shows you simple negligence. There is also transfusion, which is not accessible, which can help treat many patients with sickle cell crisis. Patients who have acute chest syndrome may need exchange transfusion. We don't have it. Multi-organ failure may need exchange transfusion. Acute chest syndrome may need exchange transfusion. Priapism may need exchange transfusion. So we are failing these patients in every way back home. We should also know that by giving these patients blood, they could get iron overloaded, which is another complication in itself. They could also react to blood when you have given them so much blood. So you have to be able to identify haloimmunization that occurs. L-glutamine is another treatment for sickle cell, which is not yet properly available back home. It was FDA approved in 2017. We need to start fighting and advocating for this drug to be sent back home. Here is a clinical trial. You also have, it shows that it reduces the number of crises. Here is crizanlizumab, which was approved, and we give it once every month. And one of our panelists will mention it. It also reduces your crisis tremendously in addition to hydroxyurea. So here is the mechanism of action, which is not important for our discussion today, but it's just to show you that this works. This is Velsalotol. I've given it to several of my patients. It also increases your hemoglobin level and reduces the number of transfusions. And there is gene therapy. This was the first case of gene therapy that was done in the world. There have been other cases that have followed, which I'm going to present. There is something called CRISPR technology, which we're using in order to edit the gene and be able to cause you to stop producing sickle cells and now produce hemoglobin F, which in high numbers, and you no longer sickle. So here is just a recent study that was published for several patients who have actually had the CTX001 study where they use the CRISPR technology in order to actually edit their genes. And these patients have been doing well since the editing of the gene. This is just showing you how it occurs. I'm not going to go into the detail unless someone has a question during discussion, we can talk about it. And one of the centers where I know of a patient who had this done. So there is another research that was done, similar thing, but using a lentivirus in order to edit the genes. We had several patients with bone marrow was collected, gene was edited, and later on the patients was reinduced in these patients as bone marrow transplant. And these patients have all done so well. This is actually showing you so far, before I come to the end of my presentation, there has been new interest in sickle cell, and there are several drugs in development. General principles is that we should be able to provide contraceptive to these patients so that they don't get pregnant when they don't want to. We should be able to provide vaccination to them, establish good laboratory system which can diagnose this patient, do screening when they are young and when women are pregnant so that we know early. Also educate these patients, do genetic counseling before marriage, socio-demographic characteristics, nutrition is very important, eye exams, without forgetting folic acid. Sickle cell patients need to be on folic acid, 1 tablet daily. If you're a sickler and you're not on that, talk about hydroxyurea, L-glutamine, crizanlizumab, and also vosalotol. We need to be able to, when surgeons want to take them for surgery, should be able to know that what to do for sickle cell patients before taking them. Once they are admitted to the hospital, all physicians need to be able to take care of these patients effectively and prevent complications to these patients. There is also the part which I'm going to talk about, stigma, bias, and racism. There is stigma in sickle cell in the sense that we do not actually acknowledge that these patients live among us. There is stigmatization living with sickle cell in itself. In the US, most of my sickle cell patients are stigmatized for being pain addicts and demanding for pain medications. And so it's something that I really advocate for. I have had cousins and others who are considered siblings who have sickle cell, and I know the pain they go through. I don't feel it because I'm not a sickler. There is a bias, an intrinsic bias when you are a white taking care of a disease that is predominantly Black. There is also racism that exists in sickle cell. There is structural racism that can be shown. Sickle cell existed in America for the past 600 years since slavery started, but it was discovered just 100 years ago. What happened to all those who were sickle that came from Africa? You can tell me. So this diagram is so important. When you look at a sickle cell patient, this is how they look. What I look like versus how I feel. So do not neglect and this is a very important disease that we need to talk about. My general statement back home is that we lack care, appropriate care centers to take care of these patients. Pediatricians are actually catching up back home, but those in the internal medicine to take care of these patients are left behind. And more needs to be done. Patients need to be screened. So I just want to say, I think I'll leave the others to talk and I'll stop sharing. Thank you.
Yeah, merci beaucoup, Dr. Foma, pour ce brillant exposé. Il faut dire que c'était très instructif pour tout le monde, je l'espère, mais pour moi, c'était vraiment très instructif avec la revue de la littérature très poussée, à la fois sur l'épidémiologie, la physiopathologie de la maladie, la présentation clinique des malades, mais aussi les complications qui sont un point très important pour la prise en charge de ces malades. Enfin, les différentes options thérapeutiques, on a bien qu'elles ne soient pas disponibles chez nous au Cameroun. Et les mots-clés que moi j'ai pris de la présentation et que je veux partager avec les participants, il est important pour tous les patients drépanocytés, notamment les femmes, d'accorder la contraception si elles ne veulent pas concevoir, de faire une prise en charge adéquate, notamment des crises vaso-occlusives, de faire une éducation notamment sur la nature de la maladie, un conseil génétique pour les couples qui veulent avoir des enfants et qui ont des allèles drépanocytaires, mais aussi un accompagnement psychosocial de la maladie. Enfin, les contrôles annuels qui sont importants, mais aussi et surtout la stigmatisation pour laquelle il faudrait vraiment chacun de nous à son niveau travailler. Merci beaucoup pour l'exposé. Et Elvis, je veux me permettre de prendre la température dans la salle.
Oui.
Et je voudrais appeler au hasard Mireille Kamda. C'est possible d'avoir vos impressions sur la présentation jusqu'ici?
Alors?
Oui, on vous écoute.
J'ai aimé la présentation. Je m'excuse, j'étais en train de faire d'autres choses en suivant. C'est ma première fois de venir, de me joindre sur le réseau. J'ai toujours essayé plusieurs fois, mais aujourd'hui, j'ai eu j'ai eu l'occasion de le faire et je suis très contente. Et j'ai aimé, et surtout le sickle cell. Je voulais savoir au moins comment ça se passe au Cameroun par rapport à ici. Oui, bon, j'ai une idée au moins et je pense que ça va m'aider à voir comment, si j'ai l'occasion d'être au Cameroun, et comment je peux aider de mon côté à résoudre certains problèmes dans le sens d'aider nos frères et sœurs qui souffrent de ce que c'est au Cameroun.
Merci beaucoup. Merci d'être là et nous espérons vous revoir aussi très prochainement selon votre disponibilité.
Merci beaucoup aussi.
Elvis, tu voudrais bien appeler quelqu'un d'autre, peut-être en anglais?
Yes, it's really a very exciting presentation by Dr. Foma. You could see the passion with which he was doing this presentation. And of course, we always call randomly to know, Christian Mofo, how is the temperature in the house today? Young.
The micro, yeah.
And unmute.
Yeah, I'm sorry.
Okay.
I'm so glad to take part in this discussion today. Sickle cell is one of the diseases that I think during my practice as a general practitioner, I had a lot of interest in, notably because I had a friend who had it, and it made me to develop interest in it. And I'm glad to follow the presentation from Dr. Foma. I've learned a lot to add to what I already knew. Thank you.
Great. Thank you very much. And
Elvis, can I make a little comment?
Yes.
That was Dr. Mufo. He's in the US, and that friend is me. He was talking about me. He was the first person who laid me a urinary catheter when I was still, I don't know, 17, 18 years old. So yeah, we are brothers. Like, he knows everything about my illness. He has been there all through all of the steps. And I was very lucky to have him in my life. That's what I wanted to say.
Oh, thank you. That's so special. Thank you so much, Christian, for being there and to be recognized by someone who is going to be our own speaker today. So thank you so much. And
thank you, Dr. Ndum.
Yeah. So Christelle, who is next?
Oui. Nous avons le plaisir d'accueillir parmi nous Madame Echi, Are Echi, qui va nous faire un témoignage, une présentation. S'il vous plaît, vous avez la parole.
Okay, so let me get to her. Yeah. So, yeah, so good.
Good evening, everyone. Yeah. It's a pleasure to be with you all today. Thank you for the invitation for the Cameroon Town Hall. I am RH. I live with sickle cell. From my experience, I started doing advocacy work because, well, the attitude of our community towards people living with sickle cell leaves much to be desired. And I felt that telling our own stories is the first point in raising awareness towards generally, my personal experience with sickle cell is a bit different from others because majorly I've been able to receive good quality care, mostly because of support from my family. But I do understand that that is not the experience of everybody living with sickle cell. Advocacy has made me see that this is very, very true in a large way. For example, we all know that one of the basic needs of a human is access to good quality care. Certainly, that one is mostly missing in Cameroon, and it makes it very difficult for people who live with sickle cell to have that quality care and management of our conditions. Infrastructure is very poor on a large part. Structures in place are not well equipped to provide the necessary care we need. It could be surprising to know that even in reference hospitals, sometimes you go there and you cannot be able to have, in most cases, it's causes of death and sickness. Also, many believe that blood transfusion is essential to sickle cell care, even though I'm not a very huge fan of that. But I do understand that the challenges of having this blood when needed is very difficult because most of the times they are not readily available. And when it comes to basic care, essential medications are missing. You say something like folic acid is available, but for example, because it's 2,500 francs for 3 months, but sadly, this 2,500 francs is difficult for many people to access. It is possible to make such a drug readily available for free for those who need it, but that is not possible in our country, and that is why we started a medical outreach drive last year, where we started providing these medicines to people living with sickle cell who have difficulties to get them. So our hope is that when we provide it, at least we elevate them for 3.5 months to have this basic medicine. We have been able to do this to 200 warriors already. And it's something we are going to do again this June to reach another 200 warriors. And our desire is that it's something we want to keep doing for as long as possible so that we reach so many people across Cameroon. And if only the hydria is available in Cameroon, but sadly, the cost, not everybody can afford it. Sometimes I buy this for 12,000 francs. So we didn't have fun in how many people can afford this drug for 12,000 francs. It's not possible. So it makes it difficult for people who are on it to keep treatment because you have to be available. You have to be able to afford it. If you cannot afford it, then it's difficult to have the treatment plan. There is another challenge that we face. Many doctors, I'm sorry to say, are not very committed to sickle cell care. I've accompanied a warrior to the hospital with severe pain crisis. But we are at the hospital, I think there was some kind of nonchalance to move up and down for me, doctor, but meanwhile, doctors were sitting and doing their own thing. And the patient was there practically dying from pain. You see, sometimes you see a patient screaming, crying, and some of the doctors there do not even care. So it makes one to wonder if the general practitioners are not committed to providing the basic care. How should we get this care? Because specialists are few, but they are not reachable to the majority. Those of us who can access a specialist, we have families supporting us, we have jobs supporting us, but it is still very difficult. And now you think about somebody who does not really have that, it makes it difficult. And the community lacks adequate knowledge. They are not readily available to learn. The media is not cooperative. So one in the sensitization is lacking. And having a platform, challenges are all over the place. We need the support, which is lacking. That is one reason why I do this advocacy with hopes that more people will be coming to help us. Thank you.
So,
Yes.
Elvis, it's important to say that HE has been a powerhouse behind advocacy for sickle cell. We brought HE. HE actually is committed. So those who are here, she has organizations that she's actually advocating for sickle cell. Today is World Sickle Cell Day. You can always contact her. She's very good at responding to emails and communicating through writing, because she has some difficulties hearing, but she's going to communicate with you always with every kind of advocacy that you want. If you want to change the life of sicklers in Cameroon, she's the one person I know who can do that. So
thank you very much, HE, for the wonderful work you are doing and for your heartwarming testimony. And it's really forces blood in our hearts to know that people like you are out there trying to give hope to the hundreds of and thousands of children with sickle cell disease in Cameroon who each day go through pain. And it really saddened us to hear from you that even sometimes doctors tend to neglect, the challenges and pain that sickle cell patients go through, and no one can actually feel that pain if you are not in that shoe. And so it is actually something really important that you continuously do this work to raise awareness, and your advocacy work is really doing a lot. And I think you really deserve so many more awards and accolades for this marvelous work you are doing. Christelle?
Oui, Elvis, je ne peux pas dire plus que ce que tu as dit et que Dr. Foma a dit. C'est un témoignage vivant qui nous interpelle chacun à son niveau de contribuer à l'amélioration des conditions de vie de tous les drépanocytaires qui sont près de nous, et aussi à soutenir la fondation que Madame Etchi a mis sur pied pour accompagner tous ceux qui souffrent de la drépanocytose au Cameroun et dans l'Afrique subsaharienne. Merci pour le témoignage qui a été pour chacun de nous très édifiant, je crois.
Yeah, thank you. And we will be able to use the town hall as a platform to see how people can support RAHE in the work she's doing. And so feel free to get into us and to see how you can be able to contact RAHE directly to support the work she's doing. This time around, we're going to transition now to Dr. Ferdinando. Everyone is excited to see you and to hear from you, and you can see people clapping already in the hall. So the microphone.
Thank you very much. Thank you very much for the invitation. This is the first time I'm participating in a town hall, and I'll do my best to give my own little contribution. Talking about this topic is going to be very complicated because it's talking about sickle cell disease, it's talking about my life. I cannot separate both of them, it's the same thing. So it's like giving an autobiography of myself, but I will not do that. I'll try to just, let people see how it is or have an idea of how it feels like growing up in Cameroon as a sickle cell patient. Yeah, my parents, as you guys should have guessed, were both carriers. And yeah, I was born with a disease. My sisters are, one of them is homozygous. She's AA. My other sister is a carrier. And I had a brother who was a sickle cell patient. He died before I was born. So yeah, I remember my first memory was of pain. I can't remember how old I was. I was probably playing, or I don't know. And I had this severe pain. I could barely walk, and I didn't understand. You see, a child who is probably 2 years old, 1 year, I can't remember, having so much pain. It sticks in your mind, you see. So that's how my life started off. And Dr. Muna already spoke about the medicine, the biology, about the disease, and Echi really gave a very emotional testimony of how the realities, the difficulties we're going through. And I'll just add a little bit to that. We have, as sickle cell patients, a double-fold burden. We have the burden of the disease itself, and then we have the burden of like external factors of how we live in a world, how the world copes with us, how we cope with the world. Yeah, the external burden. And the disease itself, there's the physical burden and then there's the mental burden. So I've spoken about the pain I started growing up with, and I had to live with this pain. I had to go to school and kind of cope with this pain. But there's also the mental aspect, right? Where you're growing up as a kid, you cannot play football with your friends because when you play, you fall sick. And I used to play. I'll play and I'll fall sick. But I had to stop when I was 10 years old because whenever I played and I fell sick, I will not sleep at night, but I'm not the only one who's going to suffer, right? My mom will not sleep. If by some ill luck, one cousin was at home who came for holidays, you have to sleep with me, I will not sleep. And all of the uncles and aunties in the house, nobody's going to sleep because I was sick. So I realized that this disease is not only a burden to the patient, it's a burden to the family, the parents, the friends, Fortunately, I learned that early enough in my life, so I stopped. I tried to limit recklessness or anything that could, although it's not recklessness, it's just being a normal person, but I tried to avoid things which will get me into trouble. Yeah. The exterior burden, for example, the health system, the stigmatization. I have to be honest with you, I had a very loving family, very supportive. I never felt at home or with my relatives that of course I was different, but my dad always made me know that I am, first of all, his son before being a patient. So I always strive to do things at school or to see myself like others, and I had a lot of support. But the government, the health system, everything was was not easy. Like if I had a crisis, I did not like to go to the hospital. I did not like it. Because I knew most of the time you go to the hospital, the stress, first of all, of being in pain and not receiving any attention, it disturbs. So it means you're sick and you're having your pain and then you're thinking of going to this Hospital Central where you wait for 1 hour and then the nurse is just staring at you and you're staring at the nurse, and you ask her that, your mom is asking the nurse what's happened, there's no bed, and she's not even answering. And those are hours and hours and hours. You feel, you have the impression that you'd have been better off being at home on your bed. At least you have people who actually care for you at home than getting to the hospital where, and I'm not pointing fingers. I'm not saying that we in Cameroon, we are heartless or anything. It's just that we have a structural health system which is not convenient for, it's not suited to take care of us. So I grew up like that, having to face these difficulties. The health system, we always spoken about hydroxyurea and so on. I didn't have, at a young age, I didn't have access to adequate pain medication. I don't know if it was because of, I can't even remember, let me see. The doctors, there was a pediatrician, I can't, to be honest with you, but I know that the drugs that I used to take, they were not really conducive, they were not really helping me with my pain. See, I used to just, there used to be Torental, there used to be a couple of drugs, we used to just play, I mean, try things. It's only when I was about 15, 16 that I started taking appropriate, real pain medication. So all of this lack of information, communication, lack of sensitization, it feels like you're growing up with a disease and you're on an island, and you know, you have this impression that the government, the state is not helping you. You have to fight with your family. You guys have to sort it out. That's how Cameroon was for me, you know. So when I was growing, I was always, I had my objectives, of course. I thought I wouldn't live till the age of 22. There was this thing that it said, sickle cell patients, there was the year 21, 22. And I always had it in mind. So I tried to make sure that I attained my objectives before that age. So I was really fast in school. I was also lucky and had support. But with 23, I was already a medical doctor. And after that, I got to Germany. And in Germany, for the first time, I realized that I could live long, that I could see beyond 40. To be honest, I thought 45, if I had to kill 40, would be. But when I got here, there were a lot of things which were different, which I would like to point out. It's very important when you have a chronic illness to be in a system in which you're confident that they can help you. These people don't have sickle cell disease. They don't have it. They don't have the gene. Where I am in East Germany, they don't even have experience with the disease. In former West Germany, there are more immigrants, so they're more exposed to the disease, and it means they have more doctors who have a little bit of experience. But where I am, they don't even have it. It's interesting that within the first 6 months, my health drastically improved because they have a system where you have a health insurance. With the health insurance, if I'm sick, I don't have to be thinking about cash, thinking about where am I going to get cash to go to the hospital and look for a doctor. No, you just go to the hospital and they'll take care of you. It's all regulated, and you receive the best quality healthcare without having to beat a sweat about, you know. So that's already a burden which is lifted. You're not worried about the financial aspect of it. Yeah? Everything is organized. I mean, there were no queues. That's just general things, just basics, things which, if we could just somehow try to improve in the country, is going to go a great way in helping our people. And then I had I arrived here in January 2016. In June, I had an operation because you spoke about on your presentation about this called cystolithiasis. So I had the gallstones, I had them, and it was causing me a lot of pain back home. And although I was a doctor, I didn't trust our doctors. I was like, okay, if I'm going to Germany, I'd rather wait with this pain for 5 months, 6 months, suffer a little bit. Then when I get there where they have all of the laparoscopic, they have all of these things here, I'll let them do it here. And that's what happened. I got here, I had a very good operation. I barely have any scars. And after that, immediately after that, my health started improving. After the operation, around the time I had the operation, I started receiving hydroxyurea. I forgot about this. Back home, I didn't receive hydroxyurea. It's not because I didn't know that there was I knew that it was hydroxyurea. I knew what it was. But Echi also spoke about accessibility to the drug, how expensive the drug is. It wasn't a big, we could have afforded, we could afford for it, of course. Like we could make the sacrifice, but when you're taking hydroxyurea, you also have to have a health structure, a system follow-up, a very good follow-up system, because hydroxyurea has effects on your bone marrow. It could lead to a bone marrow suppression in the long term. We always have to check. You have to have regular checkups. You have to have at least once a month, if possible, once in 2 months, which is almost not possible back home. There's just a lot of things which were not conducive for somebody back home to get the treatment. First of all, the price, and then the next thing is what next when you're getting the treatment? Do you have the follow-up? Do you have the doctors who have the know-how, who know exactly how to follow you up? You don't have confidence in the system, so there's all of these things. Yeah, so I started the drug, and then the insurance, the operation. Suddenly my health improved. I started doing sports, and I started planning for my future. I mean, these are all things which back home, it's not like I was dreaming. Of course, I was optimistic, but it was gloomy back home. To be honest, I was not well back home. So I really hope that we, step by step, we look the big picture. We try to improve these little things, which are just basic things, just basic things. And that's the beginning. We should start from there. And then step by step, the whole thing is going to get improved. There's no point sending drugs back home. Of course, it's always going to help if you're in an NGO, in any kind of organization which supports the patients. But if you have a structure in which this help is not really properly implemented, it's not really going to make a big difference. But every iota of help is always very important for a sickle cell patient. It's very important.
Sorry.
Yeah. I would like to mention something about stigma too. It's very important that we should consider sickle cell patients as normal people. I'm a normal person. I have my normal dreams. I breathe, I eat like normal people. I'm happy, I'm sad. We're just normal people who have the extra burden of a disease which we're stuck with. So we should try as much as possible, while recognizing the peculiarities of the disease in other people, to treat them normally, at least to make them believe that they can compete, or they can also do normal things, or be with normal people, or encourage them to go to school, just take part in normal things. There was once some friends of my mother came home, and they were Christians. I've forgotten, I'm a Christian too, but they were Pentecostals, I cannot remember. And of course, you pray with people, and it's not bad to pray if somebody is sick for healing. But it quickly changed into something else in the prayer. It became a delivery session. They started trying to exorcise me from a demon of sickle cell. I was 14 or 13 years old, and I was like, if you're trying to make somebody think that you're possessed by a demon, it means, how do you expect that person? The person is, I mean, these are just little things when a child is growing up. imagine if it stuck with me. Fortunately, for me, it was just like a little joke. I didn't believe anything. We're doing gestures on my body. They're trying to remove something from me, which imagine you're stuck with that thing and you're growing up and you're like, okay, there's something really wrong with me. I have this evil spirit is lurking around me. It's going to mess you up. So we have to be careful with the way we approach patients who are sick. We have to show empathy, but at the same time, we have to try and put ourselves in the patient's shoes to try to understand how these patients are feeling. You see, the burden that we have to carry is unbelievable. It's very, very, it's difficult. And we have to encourage them to see people, to talk to people. Counseling is very important. Mental health is very important. Depression is a big, big issue with us for two reasons, both the pathophysiology of the disease and just the problems we're having leads to depression. And some of us who are lucky to have reached this age, I'm 31 years old now, I know every sickle cell patient above 20 must have a complication. I have my own complication. So, yeah, but there are positives. I believe sickle cell patients have a very, very strong fighting spirit, because for us, we fight every day for our lives. It's every day. So there's this we have this energy to dare, to be bold and to dare to do things. I'm sure that's what has been driving me all through. I'm not afraid to engage in a project. I'm not afraid. I don't see myself less competent than the person next to me, the next healthy person. So I dare to do things, and we have that spirit. If we can only channel that energy collectively, we're going to be able to do great things. So there's hope. We have to give ourselves very good role models. I had very good role models when I was growing up. My parents were very good role models, my siblings, my family, my friends. There's this friend, Dr. Mufo spoke. He helped me a lot, and he's not the only one. All of my classmates in Boya were very supportive. Many of them had given me blood transfusions before. It's unbelievable. My own classmates. And there was a doctor who was also a role model to me. Two doctors, actually, when I was growing up in Cameroon. Professor Numangu, because he tried, at least, he used to do this therapy where he used placental cells or something to develop a serum based on hemoglobin F. I don't know, Dr. Muno, if you know about it. I need to give me subcutaneous injections every 2-3 months. I don't know, maybe it helped, but I used to look up to him, and Dr. Monello.
He did a lot in investing in immunotherapy and even sickle cell, stem cell kind of therapies in many other diseases. So
yeah. There was also Dr. Monello, his soul rest in peace.
Yeah.
He was also a good role model for me because he was also a sickle cell patient. If I'm not mistaken, he was.
Yes, you're right. He was a sickle cell patient. He was my professor. He
was one of those first people who made me think, yeah, I can make it too. So it's very important for us, if you have your friends who are sickle cell patients, their relatives, that they should hope. They should hope. If you don't hope, you cannot live. You should look up to something. You should always have a dream. You should always have a point you're looking at and you focus on it, and that gives you the energy to move on, to keep going despite all of the odds. Yeah. So presently I'm doing really good. I'll not say I'm not falling sick. I still once in a while. It's also the nature of the stress, being far from home, being a doctor too, doing a residency is very stressful. It adds an extra strain to the body, but I am doing way, way better here in Germany, and I hope we can make a difference back home so that a child who is born in a village somewhere in Cameroon from a poor family, that he can also have a chance to survive. I started taking in February this crinzalizumab. Unfortunately, it's very expensive.
Yeah.
I take hydroxycarbamide, hydroxyurea every day. And then I take once a month infusions of crinzalizumab. A little infusion is 30 minutes, is $2,000. So that's something we cannot afford with our system in Cameroon now. It's impossible. If we don't have an insurance or subsidy, it's not possible for us to have those drugs in Cameroon at the moment. At least we can, with hydroxycarbamide, we should find a way, hydroxyurea, L-glutamine. With these more specialized therapies like crinzalizumab, it's impossible if you don't have an insurance, if you don't have a system which supports you. Yeah. Okay, that's just the news. I don't know what to say, what not to say. If not, I can keep going and going and going. Yeah. So I want to thank the organizers and especially Echi, who is fighting very hard for us. We can all see some of the complications of the disease already on her, but she keeps fighting. And that's what we should take. One of the things we should take from this is that we should never stop fighting. We should never stop to dare. We should always be bold. And yeah, we'll live to see the next day.
Wow.
Yeah. Thank you.
Thank you very much, Dr. Ferdinand, with this very inspirational words from you at the end. I mean, it's amazing to see how, despite everything, you end your presentation with words of hope, and that despite all the adversity, you made a very strong statement to say, I could still find something positive in my experience, and that every other sickle cell patient might have, and that it makes them have a fighting spirit. So this is really something to take home, that despite every difficulty, challenges, you still find a window of positivity in all that experience. This is really amazing. And you said,
thank you.
Sickle cell patients have to have hope, that if you don't have hope, you cannot live. And if you don't look up to something that gives you hope, then you'll be challenged by your condition. This is really some of those strong words that I really captured at the end of your presentation. Thank you a lot. Thanks a lot for sharing
Thank you too.
your experience. I remember when we had the first talk prior to this meeting, you said you were trying to go to make it in as much as, not to make it personal, but to make it like, but you started by just saying you can't separate it from you, because it's truly your experience. And I really appreciate how vulnerable you've been able to present this talk to us. And I think a lot of our viewers out there on Facebook would have really learned a lot from you. And I'm sure parents out there who have had the opportunity to watch this session now also know that their children can go beyond the 21-year mark, which you mentioned, and also know that their children can become medical doctors and also become nuclear physicians in future, and that there is just no limit if only there is hope, but that our system need to do a lot to give this hope with the families and the children.
Exactly.
Thank you very much, you and Echi, for the incredible work you are doing. Christelle,
thank you too.
I hope you had this kind of feeling towards the end, a feeling of hope.
Oui, 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 Elvis, vraiment, c'était un témoignage très émouvant, mais aussi très encourageant pour en même temps les familles, mais les malades aussi qui souffrent de la drépanocytose. Et moi, j'ai retenu deux mots, juste deux, pour ne pas être longue, c'est l'espoir, mais aussi à garder avoir des modèles et tendre vers ce modèle chaque jour de la vie, non seulement en tant que drépanocytaire, mais en tant que soutien à tous les malades. Merci beaucoup pour ce témoignage, Ferdinand et Madame Haré, merci infiniment.
Merci beaucoup.
Yeah, thank you very much. And I think that we are going to start by having some questions from the audience. And I think, yes, I will look to see some hands that are up already. Christelle?
Oui. On a des mains, en fait, on a demandé la parole, mais nous avons aussi une question dans le chat. En attendant de lire le chat, peut-être Madame Nicole Fouda, s'il vous plaît, pouvez-vous vous adresser?
Yes, Madame Nicole.
Okay, hi everyone. Thank you so much for giving me the floor. I would like to congratulate the organizers of the town hall. That was really a great initiative. Sickle cell disease to me is like a neglected disease in Cameroon. So I'm congratulating as well Dr. Ferdinand, Mrs. Arechi for their wonderful testimonies. It was really, really so emotional. And it reminded us of the realities of the patients in Cameroon and even compared to Germany. So this is not a question, it's just a plea for us here to like support the system. I've heard everyone saying that the system needs to change, but I would just like to say something. It's really, really hard for sickle cell patients in Cameroon. I wanted to join a research on sickle cell in Cameroon because I felt that pain. And up to now, I've not been able to have any funding. And I can assure you, patients really have basic needs like paracetamol. Many of them can't get. Some lack oxygen, many lack hydroxyurea. When you go to Fondation and Central, even some of the doctors taking care of sickle cell patients, they give up. I know 2 people who gave up last year. They were like, I can't do that. I can't do that. It's impossible. And so because of that, we try to get some organizations to really fund SCD in Cameroon, like to provide drugs and even vaccines. I mean, it's really hell. Like it's difficult to do that if you can't have the means. It's like you can be compared to someone with demoniac, but they don't have the means to work. So it's pretty difficult. It's like like a vicious cycle. So all of us here, beyond having this interesting talk, we must think about what we can do to support the system, because actually, I don't think they are having well, they're doing a lot of things, but much is still to be done. So thank you so much for coming up with this interesting topic.
Thank you so much, Nicole, for your comments. We really appreciate you being in the town hall, and we hope to see you here more often. We have Dr. Ayok Foma, who's and is also on. Our own Ayok Foma.
Good evening, everyone. My name is Dr. Ayuk Foma. Sorry, I can't show my face. I have a lot of chaos going on in the background. I would really, this topic, it touches me in a very, very strong way. And I would really like to thank all the people who have done the presentations, Dr. Ndum and Mrs. Array, and all the other speakers. It's really touching. First of all, we have people in my family who have sickle cell anemia. We have people who are carriers of the gene in my family. And being a mother and also being a physician and also being a drug regulator, it touches me a lot. And I have patients. I had patients who had sickle cell anemia, both in the Gambia and in Cameroon. And also I have worked in several projects on trying to get some of these drugs into the market, regulating them and all things like that. So it really touches me a lot. One thing that Dr. Ndum said and Mrs. Ari said that really touched me, and I really want us to reflect on this as medical personnel. It doesn't matter whether you're a physician, whether you're a nurse, a physiotherapist, a pharmacist, or whatever, any part of the medical field, even a nursing assistant or anybody. He talked about the fact that when people go to hospital, the way they are treated is really bad. I'm not going to tell you a lie. When I moved from the Gambia and I came to Cameroon to work as a medical doctor, the attitude I saw was really bad. I have had experience in another African country and then moving to another African country. It was really awful. I'm not going to lie, because we need to teach customer care to doctors, to nurses, to pharmacists, to every professional person working in the medical field. We are dealing with people. We need to treat them well. We need to be kind to them. These people are already in pain. And when they come in, we do not need to add to that pain that they have. We have to show them some form of kindness. We have to be loving, and we need to because the fact of the matter is that we all tomorrow, irrespective of what you are today, even if you are the biggest cardiologist in the world, if you have a heart attack, your student might be taking care of you. Your neighbor might be the one to do CPR and save your life. So I think one of the things we need to add to the curriculum of our medical schools, the nursing schools, and all the allied health sciences is we need to teach customer care. We need to teach it in our schools, and we need to enforce it because it is very important. That is why a lot of patients are leaving us and going to charlatans and going to traditional doctors, because the traditional doctors are very nice to them. Why should people run away from hospitals? The second thing I would like to point out is the fact that we are in Africa and we are training medical personnel for the African society. We have to teach medical students and nursing students common things. Sickle cell anemia is something that is common in the African, the Black population. We are Black people, we fall under that belt. We should not go learning about things that we will never see. There are some diseases that are only found in the Caucasian communities. How many people have those diseases? We don't. But then a lot of professors will come in and force students to focus on those rare diseases that we would never see and neglect things like sickle cell anemia. Every doctor who trains in a tropical environment in Africa, in a Black environment, should be able to treat a sickle cell patient who presents to them. We should stop making our curriculum in such a way that the common things are not common. Common things are commoner. If you come out of medical school and you do not know the physiopathology of simple diseases and how to treat those simple things that are common in our societies, I think you should not have a license to practice. Nursing school, the same. Pharmacy school, the same. I think we need to change our mentality. And then when it comes to these drugs, acquiring these drugs that these patients need, it is all about the fact that our countries do not care about these people. Because the amount of money you will spend to buy a single Prado to give to somebody who does not deserve that Prado can save about 50 patients who have sickle cell anemia, can buy that hydroxyurea and give it to them. And they can have it for a whole year with one Prado. So it's about prioritizing. We do not prioritize healthcare in Africa. And it's a big, big problem. And the time when we decide to have universal health coverage, where people with chronic diseases don't need to think twice before going to hospital because of lack of money, I think we will save a lot of lives. And let us always remember, as medics, even as carers, that sickle cell anemia is something that is found in almost every family in sub-Saharan Africa. In the Black communities, even those who are living in the United States and in the Caribbean population in the United Kingdom, we should try as much as possible to make it a priority. If you go into government tomorrow, those who are going into government, try to prioritize these things. These drugs, I know they are expensive, but there are ways around it that we could get those drugs. HIV drugs are expensive, but we've been able to get them free because there is a way around it. It takes one person to go to the WHO and say, look, we want to have this drug. Can you give us subsidies to get these drugs? Can you give us a way of buying these drugs directly from the manufacturers in India or any other place, because they are making the generic ones as we speak? So in as much as these drugs are expensive, we could even have them free of charge. It just takes one person to do it. And I will finish, please, by saying that us as a community, we should learn how to empathize with others. We should see God in everyone. When people come to you and you are a doctor or a nurse or whatever you are in the medical field, see God in that person. Treat them with love. Have empathy towards them, because I have a feeling I am talking here as a physician, as someone who has practiced in Africa, as someone who is trying to get a lot of drugs into the market now. Presently, what I'm doing, it has to do with drug control and clinical trials and all the rest. But I am talking because I have personally witnessed situations where doctors, nurses, pharmacists, and other healthcare practitioners are very unkind towards patients. And it really breaks my heart, because we shouldn't have that kind of attitude. Because trust me, it can happen to anybody. One day you might be the doctor, and the next day you might be the patient. And if you do not train your students very well, your students will give you the bad training that you have imparted on them to you, and it would kill you. So please, I just want to thank all those who have come here today to testify and to make us aware of this disease, and also to plead with all of us who are in the medical field to try as much as possible to show empathy to others, because to me it is really lacking, and it really breaks my heart to know that people are being trained to go out there and save lives, yet they treat human life like it doesn't matter. It's really sad. But thank you so much. That's all I have. Thanks.
Thank you so much, Dr. Ayok, for always bringing this great advice, and your voice matters a lot to us. And one of the quotes, and I'm just quoting Dr. Ndom directly, he said, when I had crisis, or when I was in crisis, most of the times I did not like to go to the hospital. Just the feeling of being in pain and being neglected, it's like touching an open nerve. It's a very strange kind of feeling. You can be in pain and be neglected. And so that quote really touched me, because if you are in pain and you're feeling sick, naturally you should go to the hospital. So how can the hospital be that place where you can be in pain and will not want to go to the hospital? So I think, Dr. Ayok, you are right that customer care should be an integral part of the curriculum, but I think it also comes from the tradition that exists at workplace, because a lot of students get out of school and enter into the workplace, whatever they learn from school, but when they enter into the workplace, it's a kind of a culture that gets translated into them, and they start acting like those whom they have met on the field, who become their first mentors and coaches and teachers on the field. I remember at some point in time when I was doing my internship at CSU, and in the night, one of the senior female nurses said, I was wondering how I can be trained in school not to sleep on duty, and my own mentor at work is asking me to just go get a nap and sleep and rest. So we can be trained from school as much as we are being trained, but when we get on the field, we should not make the mistake of copying the culture of those who are there already. We should try to see what change you as an individual can change a workplace culture. Never neglect your own personal contribution to your workplace culture. So thank you so much, Dr. Ayok, for really buttressing this point. We have I saw the hand of Dr. Guanyala Noela.
Yeah, elle avait elle a demandé la parole, mais je ne sais pas si elle est toujours là.
Noela?
Elvi, si tu permets, peut-être en attendant. Ah, elle est là, OK. Oui, Noëlla?
Yes, present. Good evening.
Good evening, and good to have you.
Yes, thank you very much for having me. I'm Dr. Moyamoya. So I really want to stress on especially the preventive methods in Cameroon, because we can talk about the sickle cell patients, but really, how can we prevent this sickle cell? Because the number of premarital screening is really, really low. And many people are not, because I know that some countries that really put it as a law. For others, before you want to sign, you have to show your sickle cell test, which those are strategies which can be used. And also other countries, maybe, and sorry. And maybe some other countries also have conditions where they can do the prenatal screening, that's during pregnancy. So I'm really trying to really focus on prevention, which I think is really the main part of the sickle cell disease, especially the fact that in Cameroon and in sub-Saharan Africa, there are a lot of people having the sickle cell trait, which prevention is always the most important. So I want to also know the challenges which Cameroon is going through in order to prevent, maybe to do the premarital screening and also the prenatal screening in particular, because there was one research we had to carry out. We started the whole project, we did all the program, the budgeting and all that. At the end, it just stopped. So we did not finally carry out the project because they wanted to do like the premarital screening and also the prenatal screening, which I think those are the main focus of prevention. So if we can also focus, especially in Africa and in Cameroon, we focus on preventive measures. Those are really, really important notes that we should take care of. So that's really what I want to stress about. And I really want to thank you very much, Dr. Foma, for the presentation. I really learned a lot from there. And Dr. Fedzi, thank you very much for your inspirational words, because it's not easy for someone who has a disease to actually come out and actually say what they felt or how it was diagnosed. It's not easy. So I really applaud you for that. And thank you very much for the presentation. Thank you.
Yeah, thank you so much, Noella, for being part of the town hall. Maybe Mono, any words about prevention in Cameroon?
Okay, so just talking out of my experience with the disease, and I think it's more of a policy. You know, we can start at different levels, but it's policy. The fact that we do not identify it as a health priority, then we cannot prioritize it. So it starts by advocacy. We need strong advocacy, especially what HE is doing right now, to advocate that the prevalence of sickle cell trait in Cameroon is above 20%, it's between 35%. We need to advocate that to the healthcare authorities. That's the first thing. The second point about it is education. We think as doctors, I trained in Cameroon as a doctor, but let me tell, and I trained as a pathologist, but my training in sickle cell and the number of sickle cell patients I've seen in New York is 20 times more than that I ever thought I was going to see in my life. What does that tell you? It means if something is not even prioritized, a disease is not prioritized, then the training is not going to prioritize it. We used to see sickle cell patients, but I never knew a protocol how to manage their pain. As Ferdinand said, his pain was never adequately managed in Cameroon, not because the medications are not there, because nobody has a protocol in place for primary care doctors to use. Everyone who is training here in the US has a protocol. Even if you're dumb, you know this is what you have to do. If a sickle cell patient enters the ER, his pain has to be managed in 15 minutes from the time he's stepping himself in the ER, meaning that in 15 minutes, he has to be in zero pain. If not, he's admitted. Meaning you have to dose escalate till he has no pain while keeping him safe. Everyone knows that. They have what they have to use. So there is no, and our training does not prioritize it. There are several reasons that could occur. As I said, we see most of these patients in pediatry and most of them do die before the age of 5. As Dr. Nicole said, there is frustration that also steps in from the physicians because they don't have availability to training. They don't have availability to health system that can take care of these patients. Let's take, for example, just access to blood. How do you get access to blood to transfuse a child when the child is sick, when they're having, let's say, they have a sequestration of the spleen and they may need many units of blood? You need to call their mother to call all their cousins to look for 5,000. I'm just giving you what really happens in Fondation. You rush there, you try to get all of this and it's subsidized, but still they don't have it. And if we're not providing universal health care for all, prioritization of our healthcare problems would come back with the same thing. Now, going to screening, even the fact that doing screening prenatally is all about prioritization for every country. Ghana does it through Novartis Adventist. Kenya does it, they just started. But Ghana does it for all pregnant women, are screened during pregnancy. And actually, we do know exactly by the time that this is what is happening, prenatal screening. It's done for all pregnant women. We have, with COVID, we're now having all the available PCR machines. We can always use that. We need people who are going to do strong advocacy. The next thing for premarital issues, marriage is a complicated thing on how you're going to deal with it. Even here in the US, we do, screening is important. As you said, it's a means of prevention. People should know and know their risk. But the question is, there are people who have certain risks and will be willing to go through that risk. That's just how life is. Now, mandating it that if you see you can stop love by, you need to get people who are in love, it's difficult to break them or make a rule. You become an authoritarian. I'm one of those who believe in providing people information and let them decide what they want to do with it. That could be wrong, but you want to have that access. They know that I am AS. My wife is AS. We have a chance of having a SS baby. Then we can screen for it and then see what we're going to do and start treatment early for this child. The earlier, the better this child lives a normal life. Access to drugs is about, there are many drugs that are found in essential drug list, EVERS. You know that?
Yes.
So it's not difficult for Cameroon to put hydroxyurea in an essential drug list. It's a generic drug already.
Yeah.
They just need to put it in the essential drug list. That's all. And make it 100 francs. The second thing Ferdinand talked about is that hydroxyurea is not a paracetamol medication. Doctors need to know how to monitor patients who are taking hydroxyurea. It's a cancer medication. We're using its side effects to treat sickle cell. The side effects of hydria is that it causes the amount of hemoglobin F in your body to go up while killing cells. So you need to be able to understand how this drug works. All medical doctors, students need to understand and know how to dose it. Dose escalate. He's going to tell you, we start at 500, we go up and we see how you tolerate it to 150 maximum. So we don't just put you on Hydra and go have a breakfast and sleep. Once you have had your adequate dose, then you're able to stay permanent. Like the guy I showed you is actually from my clinic. He's a football player. He actually has sickle cell. You can't believe it. I was telling Ferdinand the other day, I have a patient with sickle cell thalassemia who is 85. My oldest sickle cell patient in my clinic is 75 years. Has her own complications, but she's living a good life. She just came into the hospital and just from seeing her, everybody in my hospital knows her. So it's a topic that really, I have sicklers in my family, as I said. As I told you, my great-grandmother's story fascinated me till I became a doctor. I knew when I was like in the 7th year of medical school, in my head that was sickle cell. She said she was the most beautiful woman in the village. She had her children. Those children would grow. They would reach 6 months. People would kill them. Then I came to realize that all my grandmother and granduncles were all AS. So the thing came to my mind now, and the husband died very young. So this was something that came to my mind later, and I could tell you this exists. Yaoundé, where Fondation is, that's not where all Cameroonian population is. Even when pediatricians are frustrated in Yaoundé in Fondation, I studied in Fondation, I know the structure of it. All the sickle cell patients are in Golomenduka, they are in Twerere, they are in Yagua, they are in Mora, they are in Twelebing, they are in Yoka, they are in all those places, and there is nothing. They die before you even know it.
Yeah. Thank you very much. Thank you, Dr. Muno, for adding your voice to this. And just like you said, falling in love is a natural thing. And I don't think anybody can go out there and meet a young girl and the first question is, are you sickle cell, before he falls in love? People fall in love and move on and it's at the point of making a decision about their future that they want to decide to go do a screening. And you see the progress. People fall in love, they are in love, and they make a decision to live together as husbands and wife. Then they want to go for marriage. And then that's when we start talking about screening. People don't screen before falling in love. So then that becomes where education, and I agree with you, the most important thing is to give people education and allow them now the choice of what to do with their education. But when there is complete absence of education, then that compounds the situation, even make it worse, because and this can easily be done. Imagine working with all the councils, and in the process of registering for marriage in Cameroon, you have to register and wait for a period of a month. And that period of a month is when they want to be able to see if there are any stories of anybody who come and protest the registration or whatever. That period is a period that upon registration, if the mayor can only advise the couple that before you come on that day for your signing, please try to go to your screening, your electrophoresis to see your status. If mayors can even just commit themselves to educate those who come to legislate their marriages, within that period of 30 days that is given to them as a window before they come for signing, that is also an effort. But this takes a whole, another kind of advocacy, using all the 360 councils in Cameroon to maybe you have the councils of mayors in Cameroon. You just need to get to their president and see how they can incorporate this in their counseling process, because I know mayors are also involved in counseling couples when they come for marriage. So this is another avenue that education can be provided to couples. But of course, how many married people living together have legislated their marriage in court? Not everybody goes to sign the marriage in court, but they're having children. Of course, if people fall in love and discover that they are all SS, well, we are not saying they shouldn't move together, but they can still make the choice not to have children. But even if they want to make that choice, they at least have an informed decision, that this is an informed decision they are making to bring forth kids that will be sickle cell kids. So I think that is why the importance of education, we can never overemphasize it. So Christelle, I think you see what Mono is saying makes some sense, and I agree with him that we need to scale up education.
Ouais. L'éducation, c'est la base, pas seulement avant le mariage, mais depuis le bas âge. Les écoles secondaires, les écoles, les collèges, les lycées. Déjà, c'est important de, si possible, prioriser, comme on disait, le système de santé, diagnostiquer à temps, mais aussi éduquer sur la maladie, le support social de ceux qui sont malades, l'accompagnement, mais aussi le dépistage avant le mariage. Nous avons une question dans le chat, Dr. Foma, je crois qu'on a adressé, mais peut-être je vais le lire, de Georges Limen. All these, je vais lire en anglais, parce que c'est plus facile avant de traduire.
Yes.
Donc, all these new medication, voxelotor, Acadveo, costs between $90,000 and $132,000. So I'm sure this is the main barrier to care, especially the hopes of having them back home. Not sure why, and surprised that hydroxyurea is not available in Cameroon. Je crois qu'on a adressé ça, mais si tu veux faire un commentaire.
Yeah, so hydroxyurea is available in Cameroon, but in specialty pharmacies, as Echi said, is expensive. The price is not stable, varies between 15 to 20,000 or 12 to 20,000 for a treatment or drug, most likely for 1 month, which is a 500 packet with 30 inside, which some people may take just for less than 10 days if they're taking 3 tablets. So you get to see it's more about, if it's an essential disease, the government needs to actually treat hydroxyurea like an essential drug and make it available in the essential pharmacy. So I think advocacy can be done at that level. Now, going into new medications that are just up, like voxelotor, crizanlizumab, and L-glutamine is one of those that can actually be made cheap. It's just still expensive just because it is still protected by, and I think Limen knows this very well, the pharmaceutical rights. All of these things can be negotiated. In my clinic, I have people coming from Africa that I give voxelotor to and crizanlizumab, and I give it through contacting the pharmaceutical company. And most of these pharmaceutical companies, a lot of them can actually do a lot of philanthropy work by providing some of these drugs if the nation or people contact them and actually advocate for this. And it can also go the route of HIV, where we can put pressure on the WHO, we can put pressure on those who matter, even the US government, to advocate for this whole protection licenses to be taken down and this drug should become cheaper. So this gives us the job to go ahead with advocacy. 90% of sickle cell patients are in West Africa. In Africa, and 90% in Africa are actually towards West Africa. Nigeria alone has the highest number of sicklers in the world, and not all sickle cells are the same. I would like to put that in because I had a friend who told me once, I'm sickle cell, I'm not so always feeling bad. I told him the reason is that there's lack of knowledge about the haplotypes. Your sickle cell, though everyone says you're SS and this other person is SS, your subtype could just be the Bantu subtype and the other person's subtype could be the Senegalese. That's why naturally you produce a lot of hemoglobin S by nature itself, why the other person produces no hemoglobin F. And that's why their sickle cell disease is so bad. Yours is so mild.
Good.
So it's a lot that we do in hematology to understand those things. And one thing I want to say is that in Cameroon too, the way we are structured, we do not have availability even of the right specialist. It's sad to say that could be a debate on another day. I train as a clinical pathologist, and most sickle cell patients in Cameroon are managed by hematopathologists, not hematologists. So in the pediatric sector, they are managed by pediatric hematologists, but when they move to adulthood, they are managed by hematopathologists who take the place of that because there are not a lot of hematologists trained. Most of them are trained outside the country and there are few. So this gives a gap in knowledge, it gives a gap in care. It also affects cancer care and affects sickle cell care overall. Okay.
Thank you, Mona. And Christelle, you might be thinking of one question to ask Echi while I ask Ferdinand this question.
Okay.
Ferdinand, if you are the Minister of Public Health today in Cameroon, I know sickle cell will be one of the major things you would want to take care of. And if I were to ask you that you should talk about 3 things that you would want to do to make the lives of sickle cell patients better or to reduce the incidence of sickle cell patients in Cameroon, what would be those 3 things that you will focus on?
Okay, Dr. Ndasi, thank you for the question. If I was in a position of influence, put it that way, first of all, sensitization about the disease, education, as people have already spoken about. People have to first of all know what it's about, and not only people, the whole population has to know, to be aware of the burden of the disease, what the disease is about. That's where we start from. Then the second is getting support, funding, subsidies, money, partnerships, to help treatment, medication as accessible as possible to every sickle cell patient. Everyone, when you go to the pharmacy in your village or wherever, you shouldn't be worried about cost. You shouldn't be worried about money. It should be there. It should be available because it's a big problem. The percentage, people have spoken, 20% of the population of Cameroonians are carriers. It means it's not a small thing. It's a big thing. Almost every family is affected by the disease. So as Dr. Former said, it cannot be difficult for us to put, say, hydroxyurea as an essential drug or to classify sickle cell, to prioritize the disease, So we get funding, we make it easy for patients to have access to treatment. Let me see. I was thinking of something for the third one. The thing escaped my mind when I was talking about the second, but it's great.
Ok, Dr. Ferdinand, si tu permets, le temps que tu réfléchisses pour
Oui,
le
oui,
troisième point, on donne la parole à Norbert qui a demandé la parole et à qui on n'a pas encore écouté la voix. S'il vous plaît, vous pouvez partager avec nous.
Yes, thank you very much. Hi, everyone. Always a pleasure to be with the town hall. Thank you very much for the brilliant presentation, Dr. Forma. It was amazing, and the testimonies from Ferdinand and Ari. I just want to say that there are equally other minor issues. In fact, the whole sickle cell disease is very complex, involving all organ systems, involving the health system in general, and involving the pharmacy too. And talking about the pharmacy, I want to say that it's an issue that I observed in hospitals when I was working back there in Cameroon. And one of the issues was the dosing of pain medications when it came to the management of sickle cell patients. I noticed that colleagues were generally very hesitant to give the maximum doses of pain medications when it came to pain management of sickle cell patients. I have the impression that the degree of or the severity of pain that patients go through is not really well evaluated when it comes to their management. Pain medications also at times are limited in availability. You'll be surprised that medications for pain, which should be available all the time in hospitals, at times run out of stock, and patients who suffer from sickle cell actually suffer a lot when they come to a hospital and it's just not available. So it's something that really should be looked into. And yeah, the whole issue of the price of medications is something that really has to be, in fact, universal health coverage is going to be a serious solution to most of our health problems in Cameroon. I believe that with universal health coverage, we'll probably have better remuneration for healthcare professionals, leading to better treatment of patients and hence better management of sickle cell as a particular disease. And just a small comment on the preventive techniques for sickle cell. I want to say that it will be very difficult to focus just on prevention. As Elvis mentioned earlier, there are so many limitations to premarital screening because people have babies out of wedlock. People don't really get married actually and pass in front of a mayor for some sort of counseling. People don't go for counseling for marital, for couple issues. So yeah, it's going to be very difficult to implement premarital screening as a means of prevention of sickle cell. But doing general sensitization to raise awareness on what the disease is all about and making people aware that they can carry out some form of screening and prevent the disease, I think you'll go a long way to contribute to prevention. And I want to end with a question to Are and Ferdinand. I'm sorry if I missed it. And like I said, the presentation was very awesome. But I want to find out if, with the voices that you're carrying and the personal experiences that you have, are you in any organization or, I don't know, non-governmental organization that you could stand in and, have your voices heard even louder so that the lay people in the streets can know what the disease is actually doing? And as a doctor, particularly to you, Ferdinand, I'm sure that your voice would also carry very strongly to the common man in the streets who doesn't know exactly what sickle cell is all about. So I want to find out if you are in some sort of an organization where if someone wants to give a small contribution to fight against sickle cell in Cameroon, he could pass through to where you could advocate for the financing. Thank you.
Yeah, thank you very much for the question. And just like you mentioned, our Array is having a non-profit organization she founded called Joy to Endure Foundation. And her Joy to Endure Foundation has been working dedicated to actually, give help to those who are living with sickle cell across many parts of Cameroon. So I'm sure she's here on the chat. You can private chat her and she will give you some website or more detail about her organization. And I'm sure Ferdinand, maybe you can come in to answer the other part, but I'm sure Ferdinand is also doing a lot of advocacy online, but I'm sure he might be thinking or already have some organization he would like to talk about.
Okay, thank you very much. Let me just finish the third thing I could propose, right? Yes. What Elvis was talking about. If it's possible, if we can create specialized clinics for sickle cell disease, it's not so much to ask. It's centers where if you are sick and you go there, everything from A to Z about the management of sickle cell, the doctors are specialized, everything revolves around sickle cell disease. We could have a couple of those centers in Cameroon. I know it's possible. We have the patients. It's not like, I mean, it's like having a clinic of nephrology for, there will be patients, they'll come. And that's also going to help, at the same time, help us train the young medical students, because we'll have a place where they can learn the sickle cell disease. Dr. Former is working in a clinic. He has a lot of patients. He has a lot of experience because he's exposed to the patients, because all of them they converge where he is. And that's how we learn, you see. So we can organize those centers, those hotspots where patients converge to, then it's going to not only help the patient, but also help us be educated, help the health personnel, the medical doctors to get more competent in treating the disease. Norbert, as for the advocacy, Echi is really involved. She's like a champion for us. She's involved in a lot of these organizations which help sensitize, which help sickle cell patients. I have been more or less, this is the first time I'm coming out. People don't know me. I just, because of this, I use it as an opportunity to reveal myself more or less to the public. I intend to get more engaged, especially from now on. I'm thinking of some little projects here and there. I'm going to be working closely with Dr. Former, and yeah, people hear my voice more often from now on. That's all I can say.
Thank you very much.
Merci beaucoup.
Your voice means a lot. You have the microphone and you have the knowledge, you have a testimony, you have, resilience, and the world is waiting for you to sing that song, and you have to take the guitar and make sure you sing it and for the world to listen to you. Your voice matters a lot to a lot of people, millions out there who need you to be also that role model that you talked about. So thank you very much.
Thank you. Thank you.
Yeah.
Elvis,
there are some questions in the chat box. Maybe Christelle wants to go through them. I'll just do a flash answer to all of them, like very short. There are some of them that are just easy to answer.
Yes.
Okay.
Before Christelle, maybe you bring in Bunny.
Yeah, I wanted Dr. Former, please, will you want her to intervene before you give a flash?
Yes, she can intervene before, yeah.
Yes.
Okay, please, Bunny, you have the floor. Oh, I switched to English.
You're very bilingual. That's the beauty of it.
Hello, everyone. My name is Bunye Chukwenu Mbamalu. I'm Nigerian, but a doctor who practiced in the US for 2 years. Well, studied for 2 years, but it's the same difference. I heard what was said about the percentage of sickle cell disease in Cameroon, 500,000 from 25 million population, the highest concentration in the Bronx in New York, but how it's more prevalent in Nigeria. I had a few questions and statements at the same time. I understand that sickle cell disease, although it has a 25% chance of developing an SS, it also has a 50% chance of producing survivors when both the recessive and the dominant are AS. I would say that's an advantageous position, survival position. And then there's a 25% of AA, which I guess would just be a bonus, perhaps. Not in the tropics, for sure. And it's global warming, so it becomes less of a bonus, really. That's, and given that we now know how to treat SS better and better. What was it, 18, then 21, then 48? 18 in Cameroon, 21 in Nigeria, 48 in the States. In a few years, we'll have prevention down. Hydroxyurea is very, very easy drug to produce. I should have mentioned, my first degree was in pharmacy.
Okay.
Hydroxyurea can easily be replicated once you have a dedicated AI. We already have the capabilities. We just don't have the investments. And we also have the land. Africa is huge. India are good allies. The Chinese are busy with America. I think Indians are the best allies for production, drug production. sooner or later, someone else is going to start it, I think. So it might as well be sooner. The investments most likely shouldn't be in the West. They should be in Africa, because we have land, and India, because they also have land. But in the meantime, whatever would need to be done on a larger scale should probably be tried first in the US, where there's high concentration. In the Bronx, the people are also more open to being led. That's all I wanted to say.
Okay, yeah. So I just, I work I'm in New York. So we do have sickle cell clinics here in the Bronx. We do have a lot of, most of them, we have some in Manhattan, and we do have others in Brooklyn. So they are specialized sickle cell clinics where everyone who comes there, as Ferdinand said, is a sickle cell patient. That's what we're dealing with. We turn to manage their side effects. We turn, because the Bronx alone has the highest concentration of sicklers in the world, meaning highest concentration where you could say it. It's amazing. As growing up, I could not believe there is no day in my hospital where there are not more than 2 or 3 sickle cell patients hospitalized.
Nice.
They come in, they go, and we take care of them. Yeah, so, and I did not even see that when I was growing up and being a physician back home. So it's really amazing to me how far this disease has gone. As you said, it's important to know that a disease like sickle cell, genetically, using the Wiley-Heidelberg equation I showed, had to have disappeared in genetics. If a disease like that stays, it means there is actually a factor that is promoting survival benefit. We have those who are AS had in the past millions of years that man evolved. So this has led to, now we're keeping sickle cell patients now alive. So it's going to increase the burden, kind of. The good thing is, with malaria, on the other hand, is not killing AAs anymore. So there is going to be a whole strive to go on. Then you're having those who are carriers. So we're still going to have more sicklers in the future, even develop. We're still going to be dealing with sicklers for a long time. So you're right. We should try to look for partners. We should invest in pharmaceutical industry, invest in education, and even get hydroxyurea. The good thing about it is that for the past 2 years, HASH, which is the American Society of Hematology, has dedicated the organization to fight against sickle cell. It's an amazing dedication, and it has led to the development of more than 20 new drugs that are in research. HIV is just 40 years old, having more than 28 drugs that are approved. Sickle cell is 120 years old, the highest genetical transmittable, the highest genetic disease existing on Earth, with less than just 4 drugs, with 3 of them being less than 4 years old. We had 1 drug for over almost 30 years. That's amazingly bad. And there was sickle cell in America for 400 years and nobody knew about it till 1904.
I agree. I think we both agree. And I think you're able to pitch the case very well to investors. And the best investors would probably be the banks.
Yeah, I think together we're going to do that.
Okay. Okay.
OK, merci beaucoup. Merci à tous les intervenants. Avant, le temps tire déjà à sa fin. Nous avons eu des échanges très intéressants. Mais avant de conclure, je voudrais poser la question à Madame Are Echi. Si vous avez 3 actions à proposer à tous ceux qui sont présents aujourd'hui dans le Town Hall pour soutenir votre fondation, quelles seraient les 3 actions que vous aimeriez que l'équipe ici présente et ceux qui vous suivent en live sur Facebook peuvent accorder à votre fondation pour améliorer la vie des personnes vivant avec la drépanocytose? Madame Aré?
So I just want to say, for Echi's sake, Echi has problems with hearing.
I typed
So
it.
we can type the questions. She was going to be able to respond.
Okay.
She will be able to respond to most of the questions we type.
Yeah, I just typed it to her. I'm sure she's
okay.
gonna respond.
You're still muted? Okay.
Okay. Thank you very much for the interest and the opportunity to talk about like I said earlier, presently we are doing activities to make work together. So we are raising money to buy folic acid and painkillers to distribute to warriors in Bamenda and hopefully in Kumba. We need support on that level. And also, we have a program where we want to take the sensitization to schools in September. We also need support in that because we believe that we have to help children understand the importance of knowing their genotype and to be aware. So we are taking the awareness to schools in September, and we also need support for that. And finally, we like to organize screening in remote communities. We have job as streets to organize this outreach because they have a high number of people living with sickle cell in that community, and we believe it's due to lack of knowledge. Money to go for screening, they don't know about that. So we would like to carry that activity out in the. These are the three main. These are the three main programs we have for now, and we really appreciate support. Yeah, thank you.
Yeah, thank you.
Merci beaucoup.
Yeah, thank you. And just to say it again, she says that three things. If she has to receive support from the town hall, the three things she will do. They are presently buying folic acids and painkillers to distribute in Bamenda and in Kumba, and they need funding for this. And also they plan to carry out sensitization programs in school in September, because she thinks it's important for children to know the importance of knowing their status, their electrophoresis status. And so also the third thing she plans to do is to organize a screening in some remote communities in Cameroon. And the first stop point is in Ndop, where I think the prevalence is really high of people carriers of this gene. And so I think these are the three projects that she can be very happy to implement if given the funding. I'm sure, Christelle, votre question a été
Très bien répondu. Merci. Merci
right.
beaucoup.
Okay, thank you. And Christelle, do you think we should come to the end of this? It's been a very exciting session. We already have gone beyond our time. And what do you think?
C'était une session très intéressante. Docteur Ayouk, désolé, nous tirons à la fin. Et les échanges ont été très importants. Merci à chacun d'avoir été là. Merci aux intervenants. Merci beaucoup, Madame Aré Etchi, d'avoir été là. Merci pour vos contributions. Merci infiniment, Docteur Ferdinando, pour votre contribution et votre témoignage. Merci, Docteur Foma, pour votre présentation. Merci à chacun d'avoir été là, d'avoir participé d'une manière ou d'une autre à la beauté de cette édition, la 27e édition. À toi, Elvis.
Thank you very much, Christelle. Thank you for co-moderating this session with me. I want to thank all of you, ladies and gentlemen, for being part of this session and for staying with us at this moment. It's been a very exciting day for us to listen to our panelists. Thank you, Dr. Muno Kenneth, for such an excellent presentation. We all learned a lot from your presentation. And as you mentioned, there are people who might want to get your slides, and please just send a private message to Mono if you want to get the slides, because I think they are very useful information there especially to clinicians to know some of the details and updates in treatment for sickle cell. Thank you so much for your time in doing this. And also thank you so much, Dr. Ferdinand, for being our panelist today and for speaking from that vulnerable position, but yet bringing out the best of hope to those who are having sickle cell back in Cameroon to know that they can still dream again and that they can still hope. And Madam Area Echi, thank you so much for your time. Thank you for the amazing work you are doing. Your influence and your advocacy work is incredible, and we do hope that you are going to get the support that you need to carry your projects. And I'm sure that people here in the town hall will be reaching out to you to support your work. Thank you so much, all of you who have asked questions or spoken during this session, and thank you for all our listeners and followers on Facebook. We do hope that you might have learned one or two things during this session of the town hall. We will look forward to see you again in 2 weeks' time yet for another exciting session. And accept greetings from Alison and accept greetings from Louisa and from Brian, who could not be here today, but they look forward to be with you next week. Once again, thank you for being with us, and I wish you a very nice weekend. But of course, remember, we have a parking lot session. If you want to be with us for the